to the next. So again, good afternoon and welcome to another Supporting Client Health and Wellness class presented by the Far Northern Regional Clinical Team. My name is Nellie Camarena. I'm one of the nurses from the Chico office. Here with us today are our two nurses from the Reading office, Jennifer Badger. And we also have Katie here, if you guys want to say hello.
Hello. Hello.
Yeah.
Howdy.
Hello.
Hi. So again, so nice to have all of you here. Thank you for making the time to join us today. We're going to spend the focus on today's presentation is on durable medical equipment. Just really basic, information, really touching on some of the issues that you may have experienced running into getting things covered through insurance. So we're going to go over just basic overview of insurance, criteria for DME coverage, spend some time talking about, the process of obtaining DME, troubleshooting problems, and then the importance of maintenance and follow-up. Again, if you have any questions throughout the presentation, feel free to unmute or use a chat box. So what is DME? When we talk about durable medical equipment, it's going to describe equipment and supports an individual needs to help with their health issues. So it's 3 quick clues that will tell us if it's a DME, right? It has to be durable, meaning it's reusable. It's medical in nature, so prescribed by someone, generally a doctor, nurse practitioner, physician assistant, and it has to be some sort of equipment, so not a medication or service. We know that a lot of our clients depend on DME to function in their homes and communities, as well as to help caregivers. But if you've experienced working with us, sometimes getting the DME ordered, authorized, and delivered can be super challenging for not only the client and the family, but also the caregivers, the physicians, the vendor, and can lead to delays. And so we really want to, work together on that so that we avoid having those delays and the clients can get what they need. Obviously, there's sometimes safety issues, right, when they don't have the appropriate equipment, and a lot of frustration. So hopefully, by the end of this, if you're fairly new to this, you'll have a better grasp on how to move forward whenever you come across situations like this. So before we jump into specific DME, I did want to do a really quick overview of insurances. This might be totally not anything new to most of you, but I thought it would be a good idea to talk about it just because there are a lot of types of healthcare coverage in California. We have, private insurance, we have public programs that cover, Medicare, Medi-Cal, and they all have their own set of rules and regulations. And so I'm going to do just a really brief overview of some of that. So as you know, Medi-Cal is California's version of the federal Medicaid program, right? It offers a no-cost or low-cost coverage to eligible people who live in California. And it's overseen by the Department of Healthcare Services. If you have anyone or know anyone who's on Medi-Cal, they'll typically have cards that look like this, right? Partnership Health Care Plan is the health plan for people who have Medi-Cal. And pretty much it's taken over all the counties within the Far Northern Regional's catchment area. So in the past, some counties like Butte, Tehama had Anthem Blue Cross or California Health and Wellness, but as of January 1st, Partnership has kind of taken over that. So you might see cards like this. The top is going to be the Partnership plan, and then the bottom two, the Medi-Cal. And then you have Medicare, right? Those are the 2 insurances that I'm going to be focusing on today. A little bit about, California Children's Services for kids, but really focusing on Medi-Cal and Medicare. So with Medicare, We know it's health insurance for people 65 or older, if they're under 65 with certain disabilities. And if someone has Medicare, their card, at least their Part A and Part B card, will look like something like the one on this screen. Medicare has 4 parts. Part A covers, the inpatient hospital stays, any care in a skilled nursing facility, hospice care, some home health care. Part B, which is our primary focus for today, covers, not only does it cover, doctor's services, outpatient care, but it's what's going to cover medical supplies and certain durable medical equipment. Then you have Part C, it's just a type of Medicare plan offered by a private company. And then Part D is prescription drug coverage. So you might have heard this term, Medi-Medi, and it's when people qualify for both Medicare and Medi-Cal. And they're called, dual eligible or Medi-Medi. And it's important to know the difference between, the two and understanding how they work and who's responsible for paying what, right? When someone has Medicare, Medicare is their primary insurance and it's going to pay for most of the medical care. And the Medi-Cal is their secondary. It pays for costs that are either not covered by Medicare or a portion of it. So when you hear that, it's Medi-Medi, that's what we're talking about. So both Medicare and Medi-Cal cover certain DME. As mentioned earlier, when someone has both Medicare and Medi-Cal, Medi-Cal is going to be the payer of last resort, meaning that it will only pay if Medicare does not pay. And then Medicare covers more limited range of DME than Medi-Cal does. So with Medicare, they're only going to cover DME when an individual needs it to function inside of the home. Medi-Cal coverage is a little bit broader and includes DME needed to function not only in the home, but out in the community. So with Medicare, it's the Part B, as I mentioned in the previous slide, is what covers medically necessary DME. And like I mentioned earlier, if they're Medi-Medi, then, it might be that both programs help cover costs of certain medical equipment. So Medicare might pay majority of it, and then Medi-Cal might pay for a portion of it. So that's why it's important to kind of know who's covering what and what the rules are. So you can see here, there's a lot of similarities, but the biggest difference is DME under Medicare, it's defined as equipment that's going to be within the home, whereas Medi-Cal can be in the home and community-based. Obviously, for both reasons, for both programs to cover, it has to be medically necessary. And like I said, Medi-Cal has a little bit more broader definition with that. So examples of covered services, again, a lot of similarities with both. Medicare, will cover mobility assistive equipment like walkers, wheelchairs, and scooters, again, for use inside the home. Medi-Cal, most DME is going to be covered, that's covered under Medi-Cal will generally become covered under Medicare will generally be covered under Medi-Cal. But again, with Medi-Cal, it's a little bit more broad in that it will accept, looking at equipment for use in the community as well. So I'm just going to go over really briefly examples of some types of equipment. I'm not going to go into thoroughly for each one, but just kind of wanted to share some equipment that might be covered under one program versus the other. And so we'll kind of break it up. So we'll talk about bathroom equipment here first. So bathroom equipment, such as rails, seats, stools, benches, shower hoses, accessories, are typically, not covered by Medicare. When looking at the Medi-Cal manual, when looking at specifically these types of equipment, they do allow for providers to bill Medi-Cal for this without first having to obtain a denial from Medicare. So that's always good to know. Again, all of this, I don't expect people to memorize. It's just to understand a little bit the process. The DME supplier is going to know a lot of the ins and outs of this, but it's just good to know. Again, anytime a bathroom equipment is needed, it needs to be ordered by the doctor who's currently managing the medical care for the member or the client. And so, partnership, Medi-Cal will cover, these types of equipments, the commode chair, and so on. On the next slide is a portable ramp, which is a covered benefit under Medi-Cal when a client is using like a manual or power wheelchair for home and community access. With this, a prior authorization would be required and would need to meet the criteria, right? The documentation would need to be provided. The big thing for this to keep in mind is that it needs to be portable, right? Non-portable ramps are not a Medi-Cal benefit. So with wheelchairs, Medi-Cal and Medicare have like specific criteria as to when they will consider authorizing these types of wheelchairs. And insurance is going to want to see the medical record contain sufficient information to show that the coverage criteria for the wheelchair is met, right? So they're going to be looking at really specific documentation from the provider. And this will all make sense later when we talk about DME criteria and the steps to take and why it's important to get certain players involved besides just the medical doctor, because the documentation can be really, specific. So like, for example, with like wheelchairs, insurance is going to want to see, does the, why does that individual require use of a wheelchair to safely accomplish, some of the ADLs at home? What are important medical history factors to demonstrate their mobility limitations? They're going to want a physical exam, right? To see why exactly they need it. And this is sometimes where it can be challenging because medical providers may not know. They might just submit like a generic order, and insurance is going to want really detailed information. And we'll talk about this later on in the presentation when we talk about criteria. But in situations like this where, maybe we're seeing that a client is needing a wheelchair, they've never had one, where do we start? It's a good team player to include in some of these processes is a physical therapist and occupational therapist, which we'll talk about later on, because they're really going to be able to provide more objective documentation to support the need and work as a team with the medical provider. Back to wheelchairs, there's a different kinds, like I'm listed on this slide. I'm not going to talk about them each, but there's power wheelchairs and there's different options. There's manual wheelchairs. You have the lightweight, the heavy duty, manual tilt in space, and different types. Again, we're not going to go into the details for each of one. This is primarily just to show like these are benefits. And as long as we have the appropriate documentation and assessment, it's something that should be covered through insurance. Briefly, with Medi-Cal, there is guidance on, will insurance cover a backup manual wheelchair when an individual has a power wheelchair? And according, with the manual and their definition of medical necessity is when an individual meets criteria for a power device and they meet the criteria for the purchase of a backup or backup manual wheelchair. Obviously, they need to be unable to complete some of the ADLs without a backup manual wheelchair, so documentation of that. Hospital beds, again, this is just an example, not going to go into detail for each of these, just knowing that there's different types of hospital beds out there. I didn't even include all of them here, but just to show that there's different types, and each one might have different requirements or documentation that the insurance is going to want to look into. The thing I will say though, with the enclosed beds, those are, you might have heard of it like as a sleep safe bed. Those do also require very specific documentation, and there's really specific instructions on the Medi-Cal manual. If you ever do run across, a family or a client that's needing that and you're really involved in helping them, I would say with those, it's a good idea to like reach out to the service coordinator, reach out to the nurses. We can work with you in figuring out, what exactly is needed in order to be more successful in increasing the chances for insurance to cover it. So those were there's a ton of different types of DME out there. I just went through some very brief, examples. I mean, you have standards, you have gait trainers, there's different types, walkers and all of that. I'm not going to go into all of that again today. It was really just to show you examples. On this slide, it addresses, what are some examples of services or equipment that aren't covered by both insurances. So under Medicare typically won't cover anything that's if an individual is in a skilled nursing facility, because in the skilled nursing facility, it's kind of, their responsibility to take care of it. Like I mentioned earlier, DME under Medicare has to be specifically for the home. So if it's equipment for the community, then it's not going to be covered. Items that are generally for convenience or comfort, anything that's disposable. And then under Medi-Cal, they will not cover any modification of automobiles, exercise equipment, orthopedic mattresses, books, any household items, food blenders, items that are generally not used primarily for healthcare. Sometimes, in addition, air conditioners, reading lamps, television sets, like all of that's not going to be covered through insurance. Focusing a little bit on children, California Children's Services is a statewide program that treats children up to the age of 21 who have certain physical limitations and chronic health conditions or diseases. CCS can authorize and pay for specific medical services and equipment provided by CCS. They're called CCS paneled specialists or CCS approved specialists. The Department of Healthcare Services manages the CCS program. Larger counties will operate their own program, while smaller counties like Glenn, Lassen, Tehama, they share their operation of the program with the state CCS regional offices. So only certain conditions are covered by CCS. In general, CCS is going to cover medical conditions that are physically disabling or require medical, surgical, or rehab services. So in order for a kiddo to qualify for CCS, they have to meet essentially three things. One is they're a California resident, because every county in California has a CCS program. So proof of that, proof of financial eligibility. If the child has Medi-Cal, they're automatically financially eligible. And then third, which is the big one, is obviously they have to be medically eligible. And there's different types of medical conditions that would make them eligible. I'm not going to, again, go over that, but you'll see a lot of kiddos with like cerebral palsy eligible for the CCS. And then when it comes to DME, CCS only authorizes DME for the purpose of improving mobility and self-care activities when it's limited by their CCS eligible condition. Again, the DME everything is always going to be tied to their CCS eligible condition. So if there's equipment that's needed, it has to be medically necessary to either to either treat or ameliorate the CCS condition. With this, with a lot of the CCS programs, and again, specifically, I'm picking on cerebral palsy, but there's other conditions that would be eligible. They have a medical therapy unit. When a kid is eligible for that, all their orders and assessments will be done through there. So they have doctors who specialize on assessing their needs, and they have physical therapists that can provide their input in recommending or ordering certain DME equipment. And again, with anything to be covered through CCS, I already mentioned it has to be related to the CCS condition. It's going to require prior authorization and prescribed by a CCS approved doctor. Oh, I'm looking at the chat box. I have a question. Sorry, this is for the previous slide. What about stuff used at home and community, like portable oxygen? Who would cover that? So that's a good question. Let me go back. Oh, let me go back to the other slide. So like mentioned here, I think it's going to depend, right? Because Medicare covers some, home oxygen equipment and related supplies. And like I said, anything that Medicare wouldn't cover, Medi-Cal. So like certain oxygen equipment not covered by Medicare. It would be depending, if they're needing oxygen at home and then you have the portable, it could essentially be a combination of both. Let me go back to CCS. Okay, so back to CCS, just a list of some of the things that they will not fund are listed here. What we see a lot of with our kiddos is, bicycles or tricycles, especially, when the physical therapist and the doctor have recommended it. We know it's needed, it's related to their condition, it's related to their regional center eligible condition. We'll see those, and we'll talk about later on when the regional center can assist with covering certain items. I will address that at the end. Right now, I'm focusing more on, Medi-Cal, Medicare, and CCS. Okay. So I know I went through that fairly quickly, but the biggest question we get a lot is, okay, we know that they need this. Like, how do we even get started, right? Who's responsible for ordering? Who do we contact? I think when it's CCS, I think it's a little bit helpful because especially if they're in the medical therapy unit, we know that a lot of that gets deferred back to the provider there. But with our adults or someone who maybe they've never needed DME before and now we're running into that, going over how to obtain the DME is important. So we know that sometimes the process for obtaining DME requests can be, especially if you've, again, worked with clients in this, it's time consuming, it's burdensome, and it really does require collaboration between multiple parties, right? The primary care doctor, the family, the insurance company, the equipment supplier. And when I mean equipment supplier, you might have heard some of the vendors locally, like New West, Everything Medical, National Seating Mobility. When I say DME supplier, that's what I'm referring to. So if you are working with a client that is currently at home, so not in the hospital or in a skilled nursing facility, we'll talk about that later, and you think, they've expressed or requested to be evaluated for equipment, you're working with them on this. It could be anything, wheelchair, hospital bed, and don't know where to start. The best place to start is, talking to a primary care doctor. Reaching out to the equipment supplier is also helpful too. Like I mentioned, it could be some of the local ones, New West, Everything Medical, National Seating. The primary care doctor performs the assessment and will be the ones who essentially will be the ones ordering the medical equipment, right? But it's important to include input from the supplier as well as the occupational therapist or physical therapist. I referred to that earlier today, but in the presentation, because having all of those, depending on the equipment, especially if it's something more complex, like a power wheelchair or a really specific hospital bed, they're all going to be able to collaborate and provide clarification on what factors are present in order to make individualized recommendations, especially for different types of ADLs. To get therapy involved, it might be a matter of just having that discussion with the doctor. The doctor can make an order for home health, have the therapist come to the home, do an evaluation. That way they can really assess what is going on at home and provide specific documentation, and really focusing on what the DMU will do to help either increase safety or independence with ADLs. It might be assisting with transfers, ambulation, whatever the case is, just getting them involved. A lot the DME suppliers have what's called, most of them should have an ATP or an assistive technology professional, and they are the ones who also help analyze the needs of the individuals. They can assist with the selection of the appropriate equipment. They're the ones who train the individual or the family on how to use it. And so it almost requires like an approach different ways, right? Obviously, the doctor is the one who's ordering it, but sometimes we run into issues where, they address it with the doctor orders it, but the doctor may not always know all the documentation that's needed in order for insurance to cover. So the last thing we want to do is to delay the process by like having to start all over again, right? If just sometimes the doctor might order one thing, but then the family gets evaluated by the DME supplier and they might have other recommendations for them. So getting everyone involved almost simultaneously, if it's possible, is going to be really beneficial to increase the chances of getting things covered without having to do the whole back and forth. Things aren't getting denied, more documentation is needed. So I mentioned those three components, the doctor, the DME supplier, and then the therapy evaluation. Okay. So once we know what equipment is needed, obviously an order needs to be written, right? But for majority of the prescriptions for DME, a face-to-face visit is required. So meaning the DME can be prescribed to the individual only after they've been physically examined. And it could be a telehealth too, but after they've been examined by the doctor. So that's important. So we can't just say, okay, work on this backwards, talk to the DME evaluator or the DME vendor first, have them provide the recommendations, and then talk to the doctor and ask for an order. They're going to need to schedule that appointment with the doctor so that they are evaluated, like I said, in person or a telehealth visit. The encounter with a doctor has to be focusing on the reason why they require that item, right? So if someone is asking or needing a wheelchair, then that face-to-face visit with a doctor should address specifically their mobility issues. And this is where it's helpful if they have a PT assessment that's been done, because they can, use that as a reference, use that as part of the documentation to provide to insurance. The other really important thing to keep in mind is this encounter must have occurred within 6 months of the date of the prescription. So again, just stressing the importance of by working with providers that understand which equipment is covered, which one may not. For example, like back to the wheelchair example, they're typically covered every 5 years. right? So that's good to know, because if you are working with someone who maybe already has a wheelchair and maybe it's a little run down, you've been seeing them, maybe you've been a provider for them and been working for them for years. It's good to know that those can be replaced every 5. So working with them so that it gets addressed and advocating for that individual so that they have appropriate equipment. Orthotics or ankle foot orthoses, I know we didn't talk about that, but that's another example. They're covered every 2 years, so that's good to know. It's also good to have all the key players involved, because sometimes there's multiple pieces of equipment that are ordered, and the provider should be aware of what pieces may not be covered, even if they would be covered individually. Sometimes that can get kind of tricky. There's also limits for replacement items. So there's a lot of things that goes into this. So having a basic understanding, and again, knowing who to reach out to, knowing who the DME vendor is all really important when it comes to being successful in getting services authorized. Again, making sure they've getting them all involved. I know I had an example the other day with one of the DME vendors who shared that they had a family who reached out to the doctor first, which was great. I mean, that you need to get them involved, right? Because they're the ones who are ordering it. The doctor ordered one piece of equipment, but the family never had like a PT evaluation or anything like that. And when the DME vendor got the order and went out to do their assessment with the family, they realized that maybe there was another piece of equipment that was more appropriate for them than what was originally ordered. So they kind of had to restart the process all over again. So again, just stressing the importance of getting everyone involved right away, so that there's no hiccups and there's no delay. So upkeep and maintenance. So I'm sure a lot of you have worked with individuals who already have their wheelchairs or pieces of equipment. We know that every person and every mobility aid requires different like upkeep and maintenance. So it's important that when they do or have the equipment, that this gets addressed so they know how frequently the item needs to be serviced. Again, super important, especially for like power equipment, like power wheelchairs or scooters. Even if it's operating smoothly, having an expert take a look can prevent a lot of like really expensive fixes down the line. Because we know a lot of this just, may need repairs, and it's good to get that connected. So I'll open this up in the chat box, or if anyone wants to unmute themselves, but what have you seen, or in your experience, that are some complications of wheelchair use or any type of equipment when they haven't received regular maintenance? Has anyone experienced that or worked with a client or a family? Oh, go back. So some of the things I know that we've run into or have heard from families or other providers are a lot of the times the undesirable effects and injuries associated with the wheelchair use are related to like improper fit or components that don't match the needs of that individual. So like example, an inadequate cushioning, it might lead to pressure sores. Over time, cushioning can wear down and the chair will become less supportive, right? So that can be problematic. There might be inadequate trunk support, leading to, again, pain, pressure ulcers, further deformity. So having that regular upkeep is important to prevent that. Going back to pressure ulcers, there's a lot of common sensitive areas. So like the elbow, the wrist, the buttocks area, the heel, all of those can be prone to pressure ulcers, especially if the wheelchair doesn't fit them correctly. There might be concerns with like unstable wheelchairs tipping. Wheels and tires should be routinely checked for tire balding, any cracks, any issues with the casters, looking for frame, broken parts, any rusting. All of those types of issues are things that we want to make sure get maintained or addressed so that it doesn't cause problems down the road. So if you're working with an individual, especially if maybe this is new to them, knowing how frequently things need to be serviced, right? How often should they be getting inspected? Maybe it's an annual inspection to make sure that it's in working order. And that information should come from the DME supplier, right? They're going to be the ones letting you know whether it needs any routine maintenance, any replacing of tires, brakes, wheels, example. Oh, on this slide, I apologize, it doesn't look that great. I just pasted a copy of a DME record. It comes from the UCSF Office of Developmental Primary Care. And it's super helpful, especially if you're working with families or anyone, really, to make sure that they're documenting what DME they have. Sometimes you run into issues where they don't have no idea who the supplier was, or maybe that client moved or something happened where there's no record of who provided that piece of equipment, and maybe it's time for a service or whatever it is. Knowing who ordered it, when it was last serviced, what the maintenance plan is, contact name for the vendor or anyone who's involved with that is important to keep as part of documentation. So again, this form can be referenced on the UCSF page. So now talking about supporting individuals who are in the hospital or in a skilled nursing facility. And maybe they are in need of certain DME. Maybe there was a change in their condition, which is the reason why they were hospitalized, or the reason they needed to have like a short-term stay at a skilled nursing facility, and it's related to mobility or whatnot. There's teams, there's players, both in the hospital and the skilled nursing facility, that can help the families get appropriate assessment and orders for certain equipment so that they can be able to go home safely. So when they're in the hospital, hospitals have case managers, right? So if there is need for anything for when they go home, it's important to meet with the discharge planner, and they can help kind of coordinate all of that, right? Same with the skilled nursing facility, they're going to have a care coordinator there too. And it's important to meet with them as well, because they can help in coordinating those supports and assessing, what their bathing, dressing, bathroom, therapy needs is going to look like, especially when they go home. Making sure that they have all of that, right, prior to when they go home is going to be really important. So asking, are they going to require a wheelchair, a walker, any special cushions, grab bars, any assistive devices? Knowing all of that ahead of time is going to be super helpful. If they are in a skilled nursing facility and maybe there's some changes in their condition, and you recognize that maybe they do need certain pieces of equipment from the home, ask the discharge planner. Sometimes they can get the therapist from their facility to do a home evaluation prior to the individual going home, and they can work together on ordering specific equipment to fit their needs. Sometimes they might not have it, maybe they don't have the resources, or maybe they're short staffed, but it's always a good idea to ask and see if that's an option. The other thing too is whether it's the hospital or the skilled nursing facility, they can order home health as well. And that can provide that additional therapy. The physical therapists that come out can also do that home assessment, might recommend certain equipment once they're home, maybe things that you didn't think about when they were in the hospital or in the skilled nursing facility. So making sure that they're involved is also really important. So if any of these, if there's referrals made to a DME vendor or a skilled nursing facility, or excuse me, a home health agency from the skilled nursing facility or the hospital, always good idea if you're, especially if you're assisting someone, is getting the contact information for the DME vendor or the home health. Because a lot of times clients end up going home, especially if they're or maybe more independent, and are needing a little bit more assistance at that point, or maybe they're with family members and didn't capture all of that. A lot of times they might go home and you're like, well, I didn't get the equipment that they said they were going to order. Who do I call now? So getting all those contacts is also super essential. So I know I'm running through a lot of different information, scenarios, situations, but one thing I did want to address when it comes back to insurances and authorizations is what to do when insurances don't cover a piece of equipment. So there's different options, both for Medicare and Medi-Cal. They both have their own, appeal process. So Medi-Cal has, or Medicare has their own, Medi-Cal does too. If something does not get covered by insurance, that member or the client should be receiving copies of documentation explaining why it was denied, right? In Medi-Cal, with Medi-Cal health plans, it'll show up as a letter. It's going to be called a notice of action or a NOAA that tells the supplier why a piece of equipment was either delayed, modified, or denied. And it should also give instructions on what to do in order to have the decision reconsidered through an appeal, or sometimes you might hear it called like a grievance. So an appeal, it's going to be a written complaint to the health plan and explains why you think, they made the wrong decision or providing additional documentation. It's always important to look at that. I know it can seem overwhelming, especially when there's a ton of paperwork and a lot going on, but reaching out, the DME supplier should also be getting a copy of that. A lot of the times that's where we're going to get information as to why it wasn't covered, right? It might be that there was missing documentation from the doctor. So not necessarily if the whole thing was denied, but they're waiting for additional documentation. So it's going to give us specific instructions on there. Typically with Medi-Cal, they give about, I think it's like 90 days from the date that the notice of action letter was received to file an appeal. And it's going to give instructions there on how that can be done. And then the health plan has about 30 days to respond in writing to the appeal. If it's an urgent matter, then typically by statute, they're supposed to respond within 3 days. So bottom line is, when it comes to this, is if something gets denied, it doesn't mean it's a flat out like, oh no, they're not going to be able to get it. It's more of, it might take a little bit more work and effort, but we need to look at why it was denied and see if there's things that we can work with the doctor or the DME supplier to provide to the insurance. Same with CCS, they have their own process. If, again, going back to the DME, if it's denied, they're also going to submit what's called a notice of action, explaining the reason for the denial and instructions on how the family can appeal. Because everyone has the right to appeal to the decision. With CCS, it's a little bit of a shorter time frame. The beneficiary has 30 calendar days from the date on the notice of action to send a letter to the county program requesting an appeal. If they, if you're working with family and they don't know where to start with that, reaching out to their case manager from the local CCS program, they should be able to provide assistance with filing that appeal. And can also help provide, an appeal form that the family can fill out. If for some reason it's been past that time frame, it's been over 30 days, they can still submit it. They just need to provide additional information describing why they didn't do it within the 30 calendar days. Go to the next slide. So this is regarding the regional center. So with the regional center, when something gets, denied, a lot of the times providers or families might reach out to their service coordinator and say, hey, like this piece of equipment was denied. Is this something the regional center can fund? And so we do have specific guidelines, and we call them, it's under what we call our purchase of service guidelines that indicate when we can or cannot fund certain things. So when it comes to equipment, the regional center can fund it as long as, certain conditions are met. And so I'm going to talk about each one of these and why each one of this is important, right? So the need for the equipment has to be related directly to their qualifying developmental disability. Okay, so that's number one. Certain other things that we'll take into consideration is the equipment essential to their basic activities of daily living, the cost effectiveness of looking at it, renting versus purchasing it, making sure the equipment is age appropriate. It has to be ordered by a doctor, right? When appropriate, just like Medi-Cal and Medicare and CCS, we're going to want to see an OT or a physical therapist recommendation. And then the other really important factor to consider besides, is it related to the developmental disability, is whether all outside sources of funding have been exhausted. So we are the payer of last resort, right? And we're bound, regional center is bound by the Welfare and Institution Code, where it notes that we have to access funding from, government, private entities, so like Medi-Cal, Medicare, CCS, private insurance, all other potential funding sources before the regional center can consider funding something. Again, in addition, the regional center can't purchase the service that would otherwise be available from these other entities, right? When they've met criteria for them, but they just choose not to go through them. So that's another factor to consider. So, just reiterating what's on here, when we're working with families in needing of equipment or individual clients, that's why we're always going to look at, okay, what has been done throughout the process? Have you done all the steps? Talk to the doctor, did the DME supplier, talk to the therapist, worked with them. If it gets denied by insurance, we're going to be looking at what the denial verbiage is, right? If it's, if it's justifiable, we did everything that we needed to do, it's related to the developmental disability, then, the service coordinator will bring it to the team to determine whether it's something the regional center will cover or not. But just stressing the importance that we have to go through all those avenues as well, and understanding that, because we have run into issues too, where, we had an individual who needed a wheelchair, and the provider told that entity, oh, well, they have regional center, like have the regional center cover it, without going through all those other steps of going through the insurance. And we need to make sure all of that gets done before it's something that the regional center will consider. Okay. So I know I talked about different things. There's some items that probably could have gone a little bit more into detail, but I really just wanted to cover some of the basics when it comes to insurances and kind of the caveats and different requirements for each one. Does anyone have any questions, anything that you want to share, or things that have worked for you when you've worked with clients and obtaining DME, or issues that you've run into that maybe wasn't addressed today that might be important to consider or share with other providers?
Hello, hi Nellie. I just wanted to mention too that our local PSA, which is the local area on aging, they have a program where it's a fall prevention program where they will actually set up a safety evaluation at home, and they fund like grab bars and other items that assist people in preventing falls. So just so you know, that program is out there. The PSA2 is our local area on aging. The office is here in Reading, but they serve all of Northern California.
Thank you. Thank you so much for sharing that. Anything else? Any other questions or comments? Okay, so thank you. I got it. Someone in the comments made a really important note. So making sure DME providers don't see FNRC and assume it will be paid and then deliver the product, and we are playing catch up and possibly the family may need to pay. That's a really good point. That does happen sometimes where when we're working with DME providers or suppliers, they really do need to understand to follow the proper steps, right? Just because someone has a regional center doesn't mean we're gonna, fund everything. We have to go through the steps of going through insurance. And even if it's not, even if we know it's something that's typically not covered by insurances, the provider still needs to, and it's related to their developmental disability, the provider still need to go through insurance because we require copies of the denials for our own, for auditing purposes and for the file. So yes, that's a very good thing to keep in mind. Thank you, Jacob, is when you're working with families, or if you are working with families and you're working with the supplier, making sure that that's addressed. Because that does make it really difficult. It's really frustrating for the family because they're being told yes, it's being covered, but didn't go through the proper, process or channels. And so we really want to avoid all of that. So if you are working with a family and let's say you've reached out, the client has reached out to the DME vendor or the supplier, they need to know all the what insurances they have. It's okay to mention the regional center, but they need to know that, if they have Medi-Cal as well, going through all the steps. And so another important thing is, keep the service coordinator in the loop in situations like that. So this SC can know what's going on and can help provide some guidance as well. Thank you, Jacob. Well, if there's no other questions or comments, thank you everyone for joining us today. And hopefully we will see you at our next month's supporting health and wellness class.
Thank you.
Thanks, Nellie.
Thank you.